Very easy to find in the clinic, and also, if somebody has supraspinatus tendonitis and you put your fingers there, they're gonna come off the table, right? So you can definitely identify that. I wanna remind you that the supraspinatus goes from the supraspinous fossa, it goes underneath the acromion, and then it inserts right there. The danger is needling too low, right? The symptoms can be lower, but that's not really where the problem is. We have to needle the tenoosseous insertion, which is typically here. You got anything going on there?
It's a little tender, but yeah, it's tender.
I feel like take another finger and put it on the spine of the scapula. Now, lean forward just for a second. Where your fingers come together is the AC joint. I don't want to needle the AC joint, okay? Instead of that, we're gonna fall off the AC joint medially. This is hard, this is meaty. Can you see this big giant depression that's there? I'm maybe a half of a chun medial of the AC joint. You can sit up. That's where I'm gonna put the needle. This much, no more. I'm taking it down until I hit the bone. Boom. I'd like it to look a little more angled. That was your fault, not mine. Oh, I'm wondering with you, is that your symptoms there? Okay, think of that. Hold on. Think of this. Is that you?
Yeah, it's kind of around there. It's around there, yeah.
It's kind of non-committal. All right. Look, if my finger is underneath the acromion, it's impossible. Does that make sense? Touch. So really, if this one doesn't make sense, please ask me, because I really do want you to get it. The deepest needle all weekend, DN1, large intestine 16. My dirty fingers are on the center of the spine. Now, if this freaks you out, maybe check it out. My dirty fingers are on the center of the spine of the scapula. I'm gonna fall off the spine superiorly. This is bony, this is meaty. And I'm gonna go at a 45-degree angle in the caudate direction towards the deepest aspect of the supraspinous fossa. Bone, small intestine 12. You could track the whole supraspinatus. We've needled every aspect of it now. I am making love to the acromion. I'm on it. And you're gonna needle back towards the posterior capsule. I'm not trying to needle into the capsule, but I would like to get this needle into the connective tissue structures that are the synovial capsule. If I could wind the connective tissue structures that make up the synovial capsule around the needle, I should be able to expand the size of the capsule, much like joint mobs, driving down the pressure and making the patient feel a lot better. So, right here is where I want to be. The only real way that you know that you're right here is that it's not going to feel bony, and it's not going to feel muscly. It'll feel sticky. That. You feel that? Mm-hmm. Mm-hmm. That number.
And you just went straight in.
Here's the lateral upper condyle. There's 3 chin or 4 fingers. That'll bring you to the humerus. Fall off of the humerus anteriorly into the depression between the humerus and the bicep. What muscle is that? Brachialis. Okay?
Mm-hmm.
Like that. All right, and here's how I would do this. Large intestine 13, yeah. Look, So, I lose you?
Can you repeat the landmarks?
Of course. Yeah, of course. For everything or just this one? Okay. So large intestine 13 is a point which is 3 chun, or 4 fingers, proximal of the lateral epicondyle. That'll bring you to the humerus, fall off of the humerus anteriorly into the depression between the humerus and the bicep. It's essentially in the brachialis. I would do this exact protocol, the whole thing, for impingement, and I would do the very same protocol for osteoarthritis of the shoulder. Look.
Wow.
Right? You've got to get some distinction between the scapula and the body. If you can't pull the scapula out at all, like you have that patient where they're locked down and there's no distinction at all, then I would say that you have no business doing this for a while. Like, I would do it, but I also have more experience. Like, this is not a place that you can just go for it. You've got to get it to pop out at least a little bit. And again, the key is this. Not so much this. Always build up the front of the shoulder. Right. I'm gonna go ahead and draw on the scapula. Let's go ahead and draw on the spine. Solid spine. Self, which is this. That is all fair game. So, do you remember yesterday how I showed you small intestine 9, 10, 11, 12? Remember? Now I'm going to show you small intestine 13, 14, and 15. Small intestine 13 and 14 really correspond with the same superior angle area of the scapula. If you take the superior angle between the superior aspect of the root and the top of the superior angle itself, and you divide it in half, such that I get a unique top half and a unique bottom half. And now if I take the center of the bottom and the center of the top, the center of the bottom is small intestine 13. The center of the top is small intestine 14. There's nodules there. I could flip right over it. His problem is a little bit higher as compared to lower. And I would say most patients, that's how it is. Wherever you think the problem is, that's where you're going to provide the treatment. This is not a place that you can just go for it. Okay? I would want to know before I just needle that vertebral border, like, what's the depth? How deep should I go before I know that I'm going to hit that bone? But no cigar, and in a place that I know is safe, I'm going to needle the back of the recess of the scapula, which is the back of the superior angle. You okay?
Yeah.
The recess is the part which is below the superior angle, above the spine, but lateral of the vertebral border. So I would say that the recess is this. That's safe. Feel there. Okay, I'm above the spine. I'm below the superior angle. I'm definitely lateral of the vertebral border. I know that this is safe. I also know this is close to where I want to provide the treatment. So I'm going to take a needle. I'm going to stick it down right here. I am going a little bit in the caudate direction because I want to put the needle in a way which is perpendicular to the scapula. Okay. I'm going to take it right down to the bone just to see how much needle does it take for me to hit the scapula. That is a 40 millimeter needle. and I'm already hitting the scapula. So, I'm gonna go to where the skin is, I'm gonna pull it out, and I know that it took that much needle to hit the scapula. That's the depth to his scapula. I would say that that's 20 millimeters. Get my dirty fingers over the vertebral border, over the vertebral border. This is where I want to needle. But just like yesterday, I'm gonna take this tissue and I'm just gonna pull it from the vertebral border onto the back of the scapula. And now I'm gonna take my needle, go in between my fingernails, and I'm gonna needle onto the back of the scapula as close to the border as possible without being over it. I am hitting the bone. It is less than 20 millimeters. I'm solid. Now I'm gonna use the tissue slack in the medial direction, this way, as I tap, 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 tap my way over the side. Now I'm over the vertebral border. And I did it in a way that was safe. Now I can tap up, I can tap down, trying to tap into his problem. Am I hitting it?
Yep. Yeah. That's a pineapple.
You know what? You're a pineapple. Hitting the bullseye?
Yeah.
Problem higher, lower? You think I'm in the right spot?
Oh, you're on it.
Okay. 10 to 15 seconds to some periosteopecking. I'm hitting the bone every single time here, no question. Now, looks like I'm deep as hell there, right? And I am, but that's because I'm putting the needle in at an angle. It's gonna take more needle to hit the vertebral border at an angle than it would if I went straight on. You with me? So it looks like it's deeper, but it's really not. I'm still on the bone here. And if I feel like I'm coming off, I can get back onto it and then continue mission. You wanna peck around here. Question between the upper trap and the middle trap. Can you see how my fingers shoved in between those two things? Right? We're gonna put the needle into this depression between the upper and middle trap. And I'm gonna needle inferior medial to superior lateral, such that I needle away from the lungs. The idea here is that you're gonna pull the upper trap up and away, and then you're gonna slip this needle underneath the upper trap in an effort to hit the levator as it's coming off the superior angle, right? So I wanna hit it, hit it, hit it, hit it, like this, in a fanning pattern. Clear? Let's see what we got here. He might need a bigger needle, I don't know. Let's try this. What you feeling there, anything?
No.
No?
Yep.
That was it, huh?
Yep.
Can you see how this gives me the ability to get the depth that I need?
It's basically pulling upper trap out of the way.
Yep, hitting it now, huh?
Yep.
Sometimes you'll get it to twitch all the way up. The levator is one which often twitches, not every time. Okay. You could do a set of 10 winds and holds here. Wind it up. Get to the pineapple.
Pineapple.
Let it go. Winds it up. Pineapple.
Yeah.
Let it go. Right? Fanning here obviously is nice. Trying to reproduce his symptoms, but at the end of the day, you absolutely cannot leave this needle in. This has got to come out because look, if I let this go, look where that needle's going. Look, look, right? Right towards the apex of the lung. Right? So this is get in, get out, but it has to come out. I feel like he needs a little bit more love, like right here. I'm just doing this based on what I'm palpating.
Yep. Yeah.
Twitch? No twitch.
Ooh.
What you feeling here?
Ooh, yep. Yep, that's the spot. Ugh, yeah.
So I'm just kind of holding it and then just winding it up, eliciting the dirt chi, letting it go. Winding it up,
Oh, pineapple.
dirt chi, letting it go, right? This hand never moves, ever, right? I always have control of the tissue. Okay? Do what you're gonna do. Get in. As close to the border and therefore the attachments of the levator as possible. But I'm gonna do it in a place where I can put it in and leave it in and be safe. Right? So it look like this. Arm behind the back position, right? You could ram your fingers right up against the border of the scapula. And we could put in small intestine 13. Bone. You okay?
Yep.
Looks like I'm off the scapula here, but I'm not. Like, I'm right at the border. I'm right at the edge, but I'm on the back. That's fine. Small intestine 14, which is more his problem. On the back. And I know that's safe. Both of those are on the distal attachment. Still not so happy with this one. And honestly, for levator scap, this is most always where the problem is. See, he's a really good communicator. There's no question.
Pineapple.
And then, you know, you could do a bunch of different things here. You could, that's okay, I'm just gonna show them that. I could come, and if it was just an attachment problem, oftentimes I'll do this. And do the two that are at the attachment. That should at least get enough electricity so that I'm able to hit the places that I want. If I feel like it's maybe an attachment and a muscle problem, well then maybe I could do this too. And I could run it from the attachment to the muscle belly. That's okay too. There you go. You can fix or adjust if you want. So there's C6, which makes this, so much hair. Is it okay if I do that? We're gonna make this C7. Down, T1, solid T1 by the way. Sometimes that's the best compliment you can give somebody. So I think what I'm showing you is C7 to T5. Exact center, each spinous process as it's stacked up on top of one another, we're gonna call midline. I'm putting from midline. So my fingers are gonna jut up to midline. Now a nice way for me to kind of scale things back for her body is, if I were measuring me, remember 1.5 chun is the PIP joints. But for someone like her, she's clearly smaller than me, except for upper traps, which are clearly bigger. Then I would use the DIP joints, right? So maybe I come to here for her bladder channel. Just kind of a nice way to think about it, this. So here, really funny name. It's a Japanese name, which is Htj G, right? In the literature and in the United States, we call it the Htj channel, just the Htj channel, and that's how it is in your book. The Htj channel is defined as a half chun from midline. I'm measuring a half chun from midline, not on midline, not next to the spinous processes. Put an H here for Htj, and I'm going to put an H here for Htj. Is everyone okay with that? Now, the outer bladder channel is, there's a lot more going on with the outer bladder channel. The only place that we really consider the outer bladder channel is the space in between the shoulder blades. Right? We're really going to use it for the muscle belly of the rhomboids. The outer bladder channel is defined as either 2 or 3 chun, which is the same thing as saying 3 or 4 finger breaths from midline. The distance that you choose depends on how much real estate there is in between the shoulder blades. So if I were to go 4 fingers on her, can you see how that puts me up on the scapula? It would help if I drew it in. Right? You can see how that puts me up on the scapula. So she's not a 4-finger lady, right? That's too close to the scapula. In her case, I think 3 fingers is probably going to be more appropriate. Okay? If I had someone that had more real estate in between their scapula, right? Someone that had a much wider wingspan, I might go 4 fingers. It is really your choice. But for her, 3 fingers seems better. I'm going to put an OB for outer bladder. Same thing on the other side. If we go superficial to deep anatomically, what do we find? Let me start you off. Ready? Skin, go. What?
Middle trap.
Middle trap. I like your style. Rhomboids. They're all paraspinals. I think you mean the erector spinae. Erector spinae are in the middle layer, and the erector spinae are made up of 3 different muscles.
Ilium distalis.
Longissimus.
Spinalis.
And the spinalis. Very good.
Something.
Also, can I buy an R? Is also in the middle layer. You said it. The serratus posterior superior, which really runs in the upper part of the T-spine. It runs from C7 to T2, spinous processes, and where's it going? That's a special one because it's going to the ribs. Good. I like to talk about the serratus posterior superior a lot because I think that that's a muscle which, if it's a problem, it often presents as thoracic outlet. I don't know why, but I've seen that a bunch of times. We know that they go from the spinous processes C7 to T5, which is why I went C7 to T5. And we know that it's going into the vertebral border of the scapula. But it's not the entire vertebral border. It's the vertebral border between the root of the spine of the scapula and the inferior angle. This is where it's coming. So the rhomboid minor goes C7 to T1. And then the rhomboid major continues T2 to T5. You know, I think about getting this one tattooed, huh?
Mm-hmm.
Sweet.
You remember this forever. We always needle 1.5 chun from midline, and then 45 degrees lateral to medial, and a touch caudate. We never go straight down. Why? Look, 1.5 chun out from midline. If I go straight down, you better be praying to the gods of transverse processes that you hit one. Because you slip in between, you're gonna end up in the lungs. Lumbar spine, kidney. Cervical spine, vertebral artery, right? That's why we always go 45 degrees, lateral to medial, and a touch caudate. The only reason why I say touch caudate is not really because I want you to go caudate. It's because I don't want you to go cephalad, right? What I want you to appreciate is if we do that, where will it put us? Let's check it out. Okay? 45 degrees, lateral to medial, and a touch caudate, 1.5 chun from midline. All the way down, hit the bone. Let's see where that is. Bazinga! That is the lamina of the vertebral arch. The part of the arch which is directly in between the transverse and the spinous process. What lives there? The multifidus. See where it puts me. Bazinga! I'm also on the lamina of the vertebral arch. In fact, the bullseye from the Htj channel is exactly the same as the bullseye from the bladder channel. Both will put me into the multifidus. So, if you were gonna go deep, what would you choose?
My bladder. Bladder gym? No.
Htj. All day. Why? Why would you go deep from the Htj channel?
It's closer to midline.
You're already closer to midline, and there's no reindeer gains with angles. Is that 45 degrees? Is that 45 degrees? Is that 45? I don't know, right? I mean, why go there if I can needle without any angle at all? It's gonna have to be more accurate. Also, in a 90-degree triangle, what's always the longest of the three sides? It's always the hypotenuse, right? The bladder channel is always the hypotenuse. It means that you're going to need a longer needle to hit the same target from the bladder channel than you would ever need from the Htj channel. So if I can needle with no angle and a shorter needle, I'm always going to go deeper from the Htj channel. In the C spine, it is a really big deal as you get into the L spine. Why? Because
half level down from the spinous process. Vertebral bodies.
yeah, so the vertebral bodies are much, much bigger in the lumbar spine, and therefore there's more space in between the vertebrae. If you were to go a half chun out directly lateral of the interspinous space, and I go directly down P to A and a touch caudate, it is possible that you end up in the central canal. Can you appreciate that? Certainly patients do not like it when you needle the central canal. They're not looking for spinal tap. That's the reason for the rule. You will never do that if you measure your Htj and your bladder channel points directly lateral of the spinous process in question. In the bladder channel, every single level, all the way up and down both sides of the spine. That sounds like a shitload of needles to me, right? So maybe we stagger them. Let's choose a level, do an Htj point. Come down a level, do a bladder channel point. Come down a level, do Htj. Come down another level, do a bladder channel point. And we could go back and forth. In this way, maybe we can minimize the number of needles that we're using to control the dose, but we can actually still hit both channels. What is the anatomical advantage, though, of needling in both channels? That's what I'm after. Why choose both? Well, think about it.
If you move lateral, you're gonna hit more of the erector spinae.
Hell yeah. So, the erector spinae muscles are made up of three muscles, the spinalis, the longissimus, and the iliocostalis. Do those muscles run superficial to deep or medial to lateral? They go medial to lateral, don't they? It goes spinalis, longissimus, iliocostalis. It is thought that the bladder channel is a bit more specific for the iliocostalis whereas the Htj channel would be a bit better for the longissimus. So needling in the Htj and the bladder channel, it gives me 2 of the 3 most important erector spinae muscles. Most of the time, I would needle both. Fair? And let's come straight down Htj point. I am always feeling, I am always palpating. I really could care less about my drawing, which is unbelievably good right here, but I care about what I feel, not what I see, right? I'm always feeling, there's the spinous process, there's a half chun out, I'm directly lateral, and I'm coming straight down P to A. Okay? You with me? You there?
Yeah.
Oh. Jeez. I didn't even put any needles in yet.
Are you just gonna do the right side?
What'd you say?
You doing the right side?
Yeah, I'm gonna do both.
Oh, okay.
Let's come down a level and let's do a bladder channel point. We'll come down to T1. We'll go 1.5 chun out, 45 degrees, lateral to medial. And a touch caudad. Not taking it down to the bone. I'm making the erectors be the target. Let's come down to T2. Let's do another Htj point. Now, if I wanted to, I could take that needle all the way down to the multifidus, right? I have no fear there because I already know that I'm over the lamina of the vertebral arch. What are you going to do wrong there? Nothing, right? So while the erectors are the target, like I do want you to feel comfortable. Like if you wanted to go deep, I could take this down to the bone. Look, bone, boom. The only way that I know that I'm in the multifidus is if I take it down to the lamina, right? Let's come down to T3. Let's do another bladder channel point. .45 degrees, lateral to medial, and a touch caudad. T4, Htj. T5 bladder. Appreciate how I always go high to low. If you don't go high to low, you're going to end up putting your fingers on top of needles in order to measure, right? And I certainly don't want to do that. That's not going to give me a good measurement, and it's going to be uncomfortable for the patient. Something like that. T2 bladder. It is the most boring thing in the whole world to teach because it is the same thing over and over again. We're going to go to the distal insertion of the rhomboids on the vertebral border. We know that the rhomboids insert everywhere between the root and the inferior angle. I'm going to take that space and I'm going to divide it in thirds such that we get an upper third, a middle third, and a lower third, or a first third, a second third, and a third third. And now I can come to the tops of each of the thirds and come directly out into the outer bladder channel. So if I go to the top of the first third and come directly out into the outer bladder channel, I get here. Top of the second third, directly out, here. Top of the third third, out, here. This is bladder 41, which is better for the rhomboid minor. This is bladder 42, rhomboid major. And this is bladder 44, rhomboid major. So I'm going to be a little bit closer with the handle of the needle to the skin. I really don't need to overcook this to get into the muscle belly of the rhomboids. And then Hans, if you wouldn't mind, I just want to show them the electric on this. You okay? And then her palm is the other side, so I'm gonna throw some in there.
Pineapple. Pineapple.
Anything that gets you like really excited? You're so stoic.
Pineapple. So you just go down each channel.
Yeah,
that the
I'm just
way-
going through the 4 steps of manual stimulation and all. There's no right or wrong on that.
There's no order that's better than another.
Nope. I just wanted to feel the dirt chi everywhere. Make sure that we have really wound everything up. Make sure we wind those collagen fibers up around the needle. Elicit mechanotransduction throughout the tissue. Okay?
Yeah.
About it. If it feels like nothing, it's not going to be helpful. If it's noxious, that's also not going to be helpful. Right? It's not going to be therapeutic. You want something which is in between. Issue someone maybe a towel there, if you wouldn't mind. This number, right? Just to get the vertebral water out, just a little bit, yep. And then anywhere in between the root and the inferior angle is fair game, right? I can palpate, 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 any of this, because the rhomboid inserts all the way. Find the place where the problem is, and then just like everything else, my dirty fingers are over the vertebral border. I pull it back just a little bit onto the back. I needle in between my fingers, tapping down as close to the vertebral border as possible without being over it. And now that I hit the bone, I'm going to use the tissue slack medially in order to tap, 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 tap. Now I'm over the vertebral border. And now that I'm there, hopefully I'm tapping into her symptoms. I could tap my way up, I could tap my way down. It is just a different border of the scapula. It's just very, very easy to get to the vertebral border. Is there any questions on that? Not something that I could leave in, get in, periosteal pecking, get out.
When you go on your...
That you need to be able to get your fingers underneath that scapula. If you can't get your fingers under the scapula, then obviously you can't needle underneath the scapula, right? You could play this game where you give her a little bit of love with your costochondral margin or with your chest, just onto the elbow, just to get this popping out, the best that you can. Then you can get your fingers underneath that scapula. It gives me both hands free. Can you appreciate that? Not comfortable for her, but it's not about her right now. For 30 seconds, it's about me. The whole time it's about me. She knows the deal. There's no doubt about it. You're going underneath that scapula because that's where the subscapular fossa is. There ain't nothing left in between the scapula and lung down. No angulation of this needle. I'm gonna come parallel with her skin and I'm gonna come directly across. The scapula is doing this right now, right? And all I'm gonna do is I'm gonna come right underneath and boom, I'm gonna hit the subscapular fossa. I'm expecting a bony backdrop. I would target where you think you need to go. My fingers are under. As always, the needle goes in between my fingernails, and I'm coming directly over. My palpation hand never moves. Parallel with the skin, all the way over. And boom, there's the bone. She took 35 millimeters on a 40 millimeter needle. She's muscular. I could do a little bit of fanning here, where I hit the subscapular fossa in different directions. That's fine. I could do some periosteal pecking here. That is the tenoosseous insertion. I could do a set of 10 winds and holds if I want to. Wind it up, get to the pineapple, let it go. Wind it up. You feeling that?
No. Yeah, I'm starting to feel it now.
Get to the pineapple, let it go.
Pineapple.
But the idea here is that you're really targeting the part of the subscapularis where the problem is. This hand never lets go. If I let this go, the needle's gonna go right towards the lungs. Not cool, right? And you can't be like my friends used to do where they try to tape the needle down. Not cool. You get in, you do what you need to do, get out. This cannot stay in, obviously. Yeah, and then lay into my hip, that's right, right? And now, if she's super relaxed, look at this, look. Can you see how much less I'm fighting her from this position? Right? The arm's not behind the back, I'm not having to crank down on it, and I can usually get the scapula to pop out a lot more. I'm not gonna do it, I'm just talking, thank you. Yeah, guide you. I could come at it this way, and I could come directly over parallel with the skin. I could even work my way on up, and I could get to the superior angle sometimes from this direction, right? Sideline just gives you the advantage of getting the scapula to pop out. Look, I got about twice as much here as what I did in prone. I was hoping you guys would be way more impressed with that, but clearly.
No,
Yeah, thanks. Appreciate it.
good idea. I love it.
Damn! Who's to say that it's not the lateral subscapular fossa, this business? Right? Like my football player from yesterday, nobody was impressed with that story either. I could take the needle here, like I did with him, and let's take, ladies is always difficult. Let's go lady parts east or west. No, I was hoping you'd help a guy out, yeah.
Oh, yeah.
Right. I don't know how else to say it, but yes, that. Right? And then you're gonna come up against the ribs, right? And then you're gonna come straight down. You are skirting the rib cage. No doubt about it. Under no circumstances can I go medially here, right? I'm coming straight down and I'm expecting a bony backdrop into the lateral aspect of the subscapular fossa. That football player, he was painful with internal rotation too. When I needled him this way, he also reported that it reproduces symptoms. So don't forget about the lateral aspect. This is particularly useful for adhesive cap. Because adhesive cap, you always want to needle the subscapularis, but you just can't get there, right? You can't get there from the medial side because they're locked down, right? So one way that you could think about it is this. Here, let me make Hans doing the needling now. Let's go on this side. So I usually invite a friend in like this, and then usually with adhesive cap, that's where they stop, something like that, right? And so I'll come and I'll support them, right, like this, and I'll come underneath the scapula like this, and then supporting the arm, I'm gonna pull her out, the scapula, like this. And now look at the real estate that I just gave Hans to work with. And now Hans can come and get that lateral subscapular fossa. Not laterally, it's a touch, maybe a touch, but it's very easy to miss, sorry.
Some more AP just going along with
Yeah,
that.
maybe a touch lateral, never medial, but down to the bone. Proper to the sternocleidomastoid. Okay. Have the patient turn and lift. Okay. Here's the sternal head of the sternocleidomastoid. And then here's the sternocleidomastoid proper as it's coming up to the mastoid process. Beautiful, thank you. The bottom of the triangle is going to be one shot above the clavicle for the same reasons that we've been talking about all weekend. And then the back of the triangle is going to be the external jugular. So he's got a pretty sweet one. Sure, he gets that all the time from the ladies. And there's our triangle. We can now check to see whether our triangle is good by having the patient turn and lift. If the triangle is right, then the clavicular head, here's the sternal head, here's the clavicular head, should run right smack through the center of the triangle. Okay, relax. So here's the sternal head, and here's the clavicular head, coming to make the sternocleidomastoid proper. And now you can make some smart ass is the anterior scalene. So we're essentially going to use the clavicular head as the target. Okay. So from here on out, if you simply stay one shun above the clavicle and you find the clavicular head and you needle through the clavicular head of the sternocleidomastoid with a slight lateral to medial angulation, you have to hit the anterior scalene. That is a way better way of doing it than the stupid sniff test. The worst test of all tests. You sniff everything. Notice that I'm needling him in a neutral position, right? If I pull this number, I don't know where the hell I'm going, right? That's not cool. Something like this. And this is one that, man, when you hit it, he knows, right? Right through the clavicular head. And usually I prefer a bazinga, but I'll take it. Right? Deep. Distinctly different, right?
Felt that all over my hand.
Yeah? Like a lightning bolt?
Mm-hmm.
Is it still there?
No, it's gone.
That's weird.
Oh, yep. That's all the way in my hand.
Is it okay there?
I mean,
Interesting.
lightning.
Is that okay there?
Yeah.
Okay. I have no explanation for that. All
That's
right.
nasty. Yeah.
Cool.
Yeah.
Stop being a baby.
You ever say oops?
No. At this point, I would say something like, "You got a dart in your neck, man. You're crazy."
Oh, yeah. Oh, that's nasty. Pineapple.
Pineapple. Is that a Vince Vaughn thing?
I know it's not like bilateral to me.
Oh, pineapple.
His anterior scalene is rocking. Yeah, you thought you didn't have any more whiplash symptoms, huh? Yeah, well, too close to like the bar receptors and all that. Yeah, because, I mean, if you start running electric too close to those bar receptors, they go haywire, then you could really give somebody a sweet vasovagal response, right? Because the purpose of those bar receptors is to measure blood pressure. So, not cool. I would say that here, I would stick with just the forceps of manual stimulation. Now, he is sensitive. He did have a whiplash in the past. I think we kind of already are kind of at pineapple.
The top one for sure.
Top one for sure.
Yeah.
So we could do a little bit of bilateral. He's probably going to be a step 2 patient, I'm thinking.
Oh, yep.
Yep.
it is.
See?
Yep.
Yep. And then this one, it's plenty, right? He's a guy where I think if we went past step 2, it would probably be too much for him. Then I would say, like from whiplash, then I would say that the sternocleidomastoid is also going to be a player, right? If this is jacked, this is probably going to be jacked too. So you can also needle the sternocleidomastoid one of 2 ways. Certainly you can needle the different heads, but honestly, the money for the sternocleidomastoid is the upper third, right? It's always the higher part. The way that I prefer to do this, okay,
Yeah.
is I would have the patient turn and lift, get a good sense for that upper third, right? I would grab it, the patient can relax, and now you're gonna needle medial to lateral skirting the underside of the angle, like this. The reason why I like this the best is it makes you respect the width of the muscle. Because if I go too far, I'm going to come out the other side, and I don't want to come out the other side. Like this. And I could do some fanning in through here.
Oh, God.
He's definitely very sensitive. And I certainly could leave that in too, no problem. Now, that's not the only way that you can do it. You can also, I just wanted some purple. Even needle it this way too, right? I ran my marker right up the center of the sternocleidomastoid. So if I wanted to go straight in, I could, right? But understand that the depth this way is the same as the depth this way, right? So as long as you don't overcook it going straight in, you're okay. I can certainly fan this, no problem.
That one's not as bad. Oh, there it is.
As long as you respect the width of the muscle, you're solid. Both of those are fine. They're unnamed points. Sternocleidomastoid. Myohyoid, right? So you got the, right? And then you're thinking, all right, anterior scalenes, sternocleidomastoid, and this business, right? This is the myohyoid, which goes to insert onto the underside of the mandible. These are the patients that complain about pain here, right? And oftentimes they'll complain about swallowing difficulty. Not difficulty swallowing, but pain with or irritation with swallowing. So you can certainly treat the myohyoid as well. I'm not gonna do it, I'm just gonna talk about it. It is in your manual. I don't do a ton of this, but there's a time and a place. You could do periosteal pecking onto the underside of the mandible, like tap, 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 and you can come over here, tap, 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 right? Hitting the insertion, make sure you stay away from the oral cavity. Or you could squeeze the tissue on the underside of the mandible, and I could needle either medial to lateral or lateral to medial, totally up to you, right? Obviously stay away from the oral cavity. Don't forget about the myohyoid. I've even taught this to tell you about the middle scalene, is make sure that the head is in a neutral position. The last thing that you want is for the head to hang down, for example, because if it does, then the TPs will open up. And if you overcook these needles, you could slip in between the TPs and then the vertebral arteries in play, right? So keep the head in a neutral position. The best way for me to explain the middle scalenes is this. Make a peace sign with your fingers, like peace, man, right? And now go to the apex of the peace sign where your peace sign fingers come together. And you're gonna put that on the mastoid process. And now you're gonna lay your fingers down the lateral aspect of the patient's neck. I am not following the sternocleidomastoid. I'm simply coming right down the lateral aspect of the patient's neck. If done correctly, there's gonna be a beautiful depression underneath both fingers. This one, the posterior one, is gonna be right over the TPs, and you can feel the TPs. This one, there's a depression because it's following the sternocleidomastoid down. If you push into both depressions, there's a beautiful bulge of muscle that comes up in between the peace sign. We're gonna go to the peak of the bulge, and we're gonna needle in a direction which is ventral to dorsal. In a perfect world, the goal is to get the tip of the needle underneath the posterior-most finger. Why do I say that? Because that's where the TPs are, and that's where the middle scalenes insert. Right? C2 to C7, right? It is fair game as soon as you drop off that mastoid process, and you can needle all the way down to C7. Do be careful as you approach C7 due to the apex of the lung. And consider that the lower that you go, the less needle that it's going to take to get to the middle scalene. Why do I say that? Because the sternocleidomastoid is moving forward, right? It takes a lot more needle in the upper part because you have to needle through the sternocleidomastoid to get to the middle scalene. As the sternocleidomastoid disappears and you don't have to needle through it anymore, you need less needle. Okay? So, peak of the bulge, and we're needling ventral to dorsal. To the coracoid.
Yep.
There. Coracoid is playing hard to get there. I'm on it now, though. This is where the attachment is. It's coming up this way, right? And so once I'm here, now I can tap my way all on the inferior part. Periosteal pecking. Come off the bone, find it again, and then get back to where you were. You want to come. So here's the coracoid right here. You're going to come in through here. My fingers are spread underneath. My thumb is where I'm going to put that needle. Right? We can pull this number, and you're going to come superior medial to inferior lateral, trying to skirt the underside of the coracoid. Right? The number one contraindication for this is implants, right? Come in superior medial to inferior lateral. Haven't controlled the tissue. Probably would have used a 50 on him, to be honest. And you're coming this way. And you can come here. Fan it, fan it, like this. And honestly, you'll typically get a lot of really nice explosions here. Localized twitch responses, that is. Okay? Did it twitch?
That first one, yeah. It hasn't since.
So just to give you an idea of where I am, right? Here's the coracoid, right? I mean, in hindsight, I would have used a 50 on him, right? Because I really wanted a little bit more muscle depth to get underneath that pectoralis major into the minor. I really don't care about the major. Like the major, in my opinion, highest one is easy because the very first spinous process that you come to when you fall off the occiput is C2. Perfect. So we'll go ahead and draw in C2. Spinous process extension. The last vertebrae that moves forward, in my opinion, is here. So we'll go ahead and draw that in. We'll draw in C7. And then scoliosis here, I think. Right? And now I would fill in the space. Right? If this is C2 and this is C6, right, then we got to add the ones that fall in between. So here's 3. 4. 5. And then I'm going to connect the dots. And this line will give us midline. In this case is kind of the exception to the rule. Everywhere else in the spine, it's 1.5 chun. In the neck, it's 1.3 chun. So like, wait a minute, 1.3 chun. It's like, that's 1, that's 1.5. Now we're in the freaking fractions. You know what I'm saying, right? So it's no big deal, right? If this is 1.5, I would measure it like this from midline. To get to 1.3, simply take one of your finger pads and put it on midline. not measured up to midline, on midline. Then lay your second finger down, and that will get us 1.3 chun. Midline, lay the middle finger down, and then come on the other side. I'm going to put a B here for bladder, and I'm going to put a B here for bladder. Is everyone okay with that? It's 0.3 chun from midline. No big deal, don't freak out. Instead of using your index finger for a half chun, simply use your pinky. And the pinky will give us 0.3 rather, 0.3 chun.
That's from midline.
It is from midline. The only one where we measure on midline is the bladder channel in the neck. I'll put an H here to remind you, Htj, and on the other side. Put an H here to remind you, Htj. By definition, bladder 10 western is 1.3 chun directly lateral of the C2 spinous process. I would take your finger, put it on the C2 spinous process, lay your second finger down. That'll bring you to the bladder channel. And then we're going to go 45 degrees, lateral to medial. And in this case, a touch caudad, never cephalad. Same point, other side. 1.3 chun, directly lateral of the C2 spinous process. 45 degrees, lateral to medial, and a touch caudad. This would be for the obliquus capitis inferior. And the C2 spinous process. Okay, so, no big deal. Take one of your fingers. I would put it right in the space between the occiput and C2. Lay your second finger down. That'll bring you to the bladder channel. And then again, 45 degrees, lateral to medial, and a touch caudad. That would be bladder 10 TCM for traditional Chinese medicine.
You're going to the bone there.
I don't have to, but I could. Right? Because it would still put me on the lamina of the vertebral arch. Same thing other side. One finger in the space between the occiput and C2 spinous process, lay my second finger down. And then I'm going to go 45 degrees, lateral to medial, and a touch caudad. So just to give you guys an idea, when I first took this class, back with Dunning years ago, you know how I started off with something that was really nice and I wanted to make everybody feel comfortable and that sort of a thing? We started with the upper trap. Well, the very first needle point that I ever put in on my boss was bladder 10 TCM. And he had us take this needle, the top one, all the way down to the arch of C1. I pooped my pants like 3 times. Let me give you the definition first. By definition, it is halfway between the external occipital protuberance and midline and the mastoid process on the side in question. I have a finger on both right now. Halfway in between brings me to here. That's the back of the occiput. I don't want to be on the back of the occiput. No, I want to fall off the occiput inferiorly And I want to tuck the needle underneath the occiput with an angulation towards the opposite side eye. No bony backdrop. Same thing other side.
That's a money shot.
Yeah,
You went Cephalad there, didn't you? Did you go?
I did. No, you asked the right question. Let's hang on just for a second on that because I'll talk about that. But I was hoping that somebody would ask that question. It's been like 5 classes since somebody's asked that question, so it's perfect. This point is halfway between the mastoid process and the external occipital protuberance. That'll bring you to the back of the occiput. I don't want to needle the back of the occiput. I want to fall off the occiput inferiorly, tucking the needle underneath the occiput with an angulation towards the opposite side eye. No bony backdrop. You okay? That's a 3-fer. What are we needling there? Well, number 1, it's the top of the goalposts, right? It is the very top of the obliquus capitis superior. Nailed it, right? But in order to get there, what do you have to needle through to get that muscle? Well, look on the other side. Can you see the muscle of the greater occipital nerve? The greater occipital nerve is huge, especially for headaches. In fact, if you go get Botox injections for headaches, the very first place they're going to put a needle is gallbladder 20. They're not going to say gallbladder 20, but it's gallbladder 20. Spot that you just felt. I'm going to needle with an angulation towards the opposite side eye. And in this case, a bony backdrop would be acceptable. Good point. Okay. A little bit of a bony backdrop there.
Madam, so what are you angling towards?
The opposite side eye.
Opposite side.
Yeah, and technically, like, it's not really the opposite side eye. It's just that what else can I say, right? Like, it's really like here.
Okay.
It's just, how am I going to describe that, right? You know what I mean?
Yeah.
Like, so the opposite side eye is really the best that I've got.
Okay.
Same point, other side. I'm going to off of it posteriorly. Beautiful depression that sits there. I'm going to tuck the needle underneath the occiput with an angle towards the opposite side eye. In this case, a bony backdrop is acceptable.
Acceptable meaning you may or may not hit it.
May or may not. The purpose of this point is the Splenius Capitis. The Splenius Capitis is a muscle which runs from the spinous processes C3 to T3, and it makes a giant V. It looks like this, C3 to T3, and it inserts into the mastoid processes bilaterally. Such an important point. This point, gallbladder 12B, is defined as halfway between gallbladder 20 and gallbladder 12 and a half chun distal. Halfway between gallbladder 20 and gallbladder 12 and a half chun distal. Needle towards the opposite side eye, no bony backdrop. You can see why this would be a really nice point because the Splenius Capitis is coming up through the mastoid process right there. So you can see why that would hit the musculotendinous junction or the muscle belly of the Splenius Capitis. Same point other side. Halfway between gallbladder 20 and gallbladder 12, and then a half chun distal. Angulation towards the opposite side eye, no bony backdrop. To get the Splenius Capitis as it's coming up to insert into the mastoid. So, your question was perfect. Why in the world would I choose to needle gallbladder 20, gallbladder 12, and gallbladder 12B purposefully towards the foramen magnum? Because I don't like him? It's possible.
needle's small.
Yeah. I'm playing the game of distances. And to be honest with you, the only reason why I'm choosing to needle in that direction is there has to be something else that's more dangerous. If you were to needle straight down at GB12 or 20 or 12B, what could you hit?
Vertebral artery.
The vertebral artery. To avoid the vertebral artery, I'm purposely needling towards the foramen magnum. But I know in a worst case scenario, the closest point to the foramen magnum is gallbladder 20. Having done this on cadavers, if you wanted to hit the foramen magnum from gallbladder 20, right, it would take at least 60 millimeters to do it. And that's like on her neck, right? So I'm saying like 60 millimeters minimum to hit the foramen magnum. I'm putting in a purple 30 millimeter needle and I'm going in 25 millimeters. It is less than half the distance that it would take to cause a problem. 15 is in midline. The governing vessel is always in midline. It runs all the way down. Governing vessel 2 is the sacral hiatus. I'll let you use your imagination where governing vessel 1 is, but if you're thinking Browntown, that would be right. Right? The governing vessel comes all the way up, and on the very top of the head is governing vessel 20, a famous point in acupuncture. Acupuncturists believe that that is the exit of the yang from the body. So if you hear about people that have like a yin deficiency or a yang deficiency, they like to use this point in order to help balance that, right? As soon as you come to the front from governing vessel 20, for the rest of the way, all the way down the front, all the way to the pubic symphysis, now it's the conception vessel, right? The governing vessel is always in midline on the back. The best way for me to explain it is this. Take your fingers and put it on the external occipital protuberance in midline. And now I want you to imagine for a second that you're one of those ski jumpers in the Olympics. The ones that they stand on top of that like really big ramp, and then they go into the ramp, they go all the way down, and then they fly for a while. Do you know what I'm talking about? Mm-hmm. And I think they measure like how far they go and if they can keep all their stuff together, you know what I'm saying, right? So you're that ski jumper. You're sitting on top of the ramp, looking down, right? As soon as you fall off the external occipital protuberance into the ramp, as soon as you hit the ramp, that's where you put the needle. Okay? So put the needle first. Right in midline. As soon as you hit the ramp. Okay? Now, take your palpation hand, and I want you to squeeze the tissue over top of the ramp. There's not a lot of tissue there. You're giving yourself something to needle into. Okay? Plus, this is nice. And now you're going to needle at an angle that is consistent with the ramp, consistent with the ski jump. In a perfect world, you'd like to scrape this needle down the center of the ramp. Or another way of saying that is you'd like to scrape it down the center of the occiput, directly in between the muscle bellies of the rectus capitis posterior minor. Like this. Squeeze, and then needle into the pinch. He has a really steep ramp. Not everybody has the same ramp off the external occipital protuberance. Like whatever that is for the patient, that would be the angle of the needle. Did I explain that well? Is the kiss of the dragon. Okay. This is in midline in the space between the occiput and the C2 spinous process. It's really only the kiss of the dragon if you go straight up, which we would never ever do. There's nothing wrong with governing vessel 15 as long as you needle down. I would needle in the caudad direction towards the top of the C2 spinous process, like that. I like to use this point a lot for patients that have had like a previous neck surgery. They've got that scar tissue in the upper neck. Usually it like adheses down, it causes a lot of pain. And needling through that scar and getting it to release a little bit can be really magic. I think that's the justification for governing vessel 15.
You say that's right above the C2, this spinous process.
It is in the space between the occiput and the C2 spinous process. Yin Shi. Yin Shi. Yin Shi is a bladder channel point like any other with a fancy name, and it's your choice. You can do this at C3 or at C4. I'm going to choose to do it at C4. I'm going to go to the C4 spinous process, 1.3 chun directly lateral, and then 45 degrees lateral to medial, and a touch caudad.
Can you repeat it?
Absolutely, we're going to do the other side. Yin Shi is a point that is your choice. You can do it directly lateral of either C3 or C4. I chose to do it at C4. I'm directly lateral of the C4 spinous process, and I'm needling 45 degrees, lateral to medial, and a touch caudad. Why has Yin Shi stood the test of time? 2 reasons. Number 1, that is the proximal insertion of the levator scapula. Levator scapula inserts C1, 2, 3, and 4 into the transverse processes. I can certainly get it there. And that is the proximal insertion of the splenius cervicis. The splenius cervicis is a really important muscle for neck pain because it's one of the only muscles associated with neck pain that does not insert into the occiput. Rather, it connects the T-spine with the C-spine. It runs from the spinous processes, T3 to T6. It comes up, arcs around, and inserts into the transverse processes, C2 to C4. Again, T3 to T6, spinous processes, up, arcs around, and then inserts into the transverse processes, C2 to C4. Yin Shi at C3 or C4 in the bladder channel allows me to get the proximal attachment of the levator scapula and the splenius cervicis. In your book, it's JBL. Jingbei Lao is also your choice. It is a bladder channel point like any other. And you can do it at C5, C6, or C7. Most of the time, I like to do it at C7. So I'll go ahead and do it at C7. 45 degrees, lateral to medial, a touch caudad, the whole thing.
1.3 chun.
1.3 chun. Same thing on the other side. And I'll tell you the reason why I like to put it at C7 is because I feel like a lot of guys in particular, you have CT junction problems. That is, your CT junction doesn't move. Your guys. So this is a big pilot problem. Anybody that's doing a lot of like heavy lifting, the Kevlar on the head, it's CT junction, right? And so what you find is the CT junction gets locked. Like that poop does not move. And then you could run a current on either side of the CT junction. You could even cross the CT junction if you want to. And then if you return to the manipulation, a lot of times it's just enough movement to do what you want to do. CT junction is a really big deal in my opinion. That is not, though, why Jingbei Lao has stood the test of time. Has nothing to do with the CT junction. It really has everything to do with the biomechanical deficiency or disadvantage. It turns out, do you remember the Splenius Capitis? This was the purpose of GB12. I told you it went from C3 to T3, spinous processes, and it went into the mastoid processes bilaterally, right? That giant V. This is what it looked like. I'm going to take away half of it now. That's half of a Splenius Capitis. And now I want you to remember the Splenius cervicis. We just talked about that. The Splenius cervicis runs from the spinous processes T3 to T6 And I told you that it comes up, it arcs around, and it inserts into the transverse processes C2 to C4. The arcing of the splenius cervicis around the splenius capitis before it inserts. This is the biomechanical deficiency. As a result of this, patients tend to develop a lot of trigger points, and it just happens to occur at C5, C6, C7. That's the reason for Jingbe Lao. You get it? There's only really one other muscle here that's worth talking about that we have. And then you're gonna go directly down P to A and a touch caudad, right onto the lamina, right into the cervical multifidus. I would at least do 2 on each side. This way you have a place to hook up the electric. Now, I'll tell you right now, that's a poop load of needles. You do that on most patients, and I promise you, you'll never see that patient again.
Especially if he sneezes.
Yeah. I mean, if you think about it, I'm just giving you options here. I would run one current from GB12 to GB20 bilaterally. Under the occiput. Those are the 2 most important points. GB12 to GB20. Then, I would run a current from the highest point in the bladder channel, bladder 10 TCM, to the lowest point in the bladder channel, which for most of you will be Jingbe Lao. This way you run it down the bladder channel and you hit all those muscles at the same time. Then, I would run a channel the highest point to the lowest point in the Htj channel for the cervical multifidus, bilaterally. That's already 6 channels. And if I had a 7th channel, I would run it governing vessel 16 to governing vessel 15 in midline. If I did bilateral upper traps, that's 9 channels. If I did bilateral levators, that's 11 channels, right? You see how quickly you start to build up the channels. Of the 4 things throughout the entire literature that has the best evidence for using needles, neck pain is the second of 4. You will find more evidence on what I'm showing you right here than anything else this weekend, with the exception of maybe headaches. The lateralmost point is gallbladder 12 for the Splenius Capitis. Then we come to gallbladder 12B. That is the muscle belly or the musculotendinous junction of the Splenius Capitis. Next, we come to gallbladder 20. That's a 3-fer. That is the obliquus capitis superior, the semispinalis capitis, and perineural needling of the greater occipital nerve. That brings us to the bladder channel, and I'm gonna go high to low. The highest point in the bladder channel is bladder 10 TCM. That is the rectus capitis posterior major. Next, we have bladder 10 western, obliquus capitis inferior. Next, we have yin shi, a 2-fer. That is the splenius cervicis and the proximal attachment of the levator scapula. Next, Jingbe Lao. This is the place where the splenius cervicis arcs around the splenius capitis, creating a biomechanical deficiency. I also showed it to you as a possibility for CT junction pain. And then I chose to add bladder 11 at T1, again, for CT junction pain. That brings us to the Htj channel. The Htj channel is all about the cervical multifidus. And then finally, that brings us to midline. The highest point that I'm showing you in midline is governing vessel 16, in between the muscle bellies of the rectus capitis posterior minor. And then finally, I showed you the kiss of the dragon, governing vessel 15, for scar tissue in the upper neck. I'm gonna show you how to needle scar tissue. I haven't shown you that yet, right? But just understand this is a nice option for scar tissue. Control whatever angle that you want.
We gotta pull the tissue up.
So as long as you tap it in, it
You
doesn't
put the
matter.
needle in first, and then like you
Needle
tap
first and then-
tap it, and
okay.
then pull the tissue, and then it's one. I'll do that, or do you want to do the next one? The angle on this one is slightly.
So you're pinching up the skin.
Mm-hmm.
Thank you for all the contacts, by the way. I
I've got a
appreciate
couple
it.
more too. So.
Thank you. I can't say thank you enough.
Okay.
And what's that one?
So this is governing vessel 16.
Yeah.
Thing.
When Ray did it, you can't.
So I want to go really caudal
That way
though.
you don't have to.
I'm gonna come in this way.
Put it in there.
So governing vessel 17 to 1.5 chun superior to the external occipital protuberance, or going off. You okay? Okay.
But
You don't hit any bone, right?
pinch the tissue.
No, I'm just skirting the top of it.
So pinch the tissue here.
1.5 chun lateral.
So if you put your finger on that one, and then shoot it on the other side.
And you have to also squeeze the tissue.
So what I'm gonna do is just like gently set it and then squeeze.
I know it's hard with the hair to, and you think you've got it, and then you move, you know. He's saying do it the same way as we did the sloping, where you actually pinch it, or you put it in, and then pinch, and then push it in as you've got it.
Got some tension there.
Okay.
If there's anyone that I would do last and never first on the first treatment, it's gallbladder 19. I have found that gallbladder 19 will provoke headaches more than any other. Just be careful with that one.
Don't do it, we'll just, how about if I just do the tube on it? Yeah.
What do you need?
All right.
So you drank a lot of Starbucks earlier.
Yeah, I got 2 Red Bulls in me now, so
You're pretty jacked.
pretty shaky.
So what are you feeling for?
The external occipital, or the inferior nuchal line, and then so just rolling up. I just want to get right on the curvature of the base of the skull. There's something right there. Five, 4, 3, 2, 1. Do you want to put your hand on there?
Pain maybe here or in between the eyebrows, something like that, right? It can be part of the same headache, or sometimes what you get is patients will say, you know, I feel like I have a knife like right there, and it comes on, and that's how I know I'm going to get a headache. like a migraine, right? And so with those patients, I mean, if it's a PT or a friend, I'll give them a needle to take home with them. You could even get like short stubby needles and then show them where to put it. And then I'll just say, like, when you feel like that's coming on, put the needle there. And then when you're watching TV at night, like every time the commercials come on, I want you to just wind the needle a little bit, just to stimulate it. And they will use that to keep the headache away. Headaches. And then I would do it bilaterally. So we'll talk about that. All right. I'm gonna start you off with a point in the center of the eyebrow, directly above the pupil, in the superior aspect of the orbicularis oculi. It is very important, pre-clip the needle, but when you approach the patient's face, the patient should close their eyes. The last thing that you want to do is accidentally drop a needle in somebody's eye, right? I would pinch the eyebrow directly above the pupil and either needle lateral to medial or needle medial to lateral. Don't needle towards the eye, obviously, and you don't want to needle away from the eye either, because I don't want the handle to be stuck in the patient's eye. You see that I'm always pinching the tissue and then needling into the pinch, like that. That point is called Yu-Yao. Yu-Yao. I don't know how to spell it. No idea. I don't know. And I'm going to needle a point called Bladder 2. This is a muscle called the corrugator. And you know this is a big deal because I think we've all seen that little old lady who comes in the clinic doing this, right? You're like, is your nose okay? And she's, oh no, sweetie, I have caudad direction, pinching the tissue into a point called yin tang. Yin tang. This would be what acupuncturists call the third eye. We know that it's for a muscle called the procerus. The procerus. Okay? Or of the orbit. And the best way for me to explain this to you is put your finger on your own lateral orbit. I want you to fall off the lateral orbit now posteriorly. Can you feel that depression that's there? Assuming that it isn't beating, we're going to put a needle there. And we're going to needle, in this case, directly towards the eye, no angulation. Now you're going to freak out with this one because you're like, oh my God, like, aren't we going to needle her eye? No. So if you dissect it here, sorry, you okay?
Mm-hmm.
Can you still see?
Mm-hmm. I don't know. Can I have that?
I can't see.
It's not exactly where I wanted to be. Sorry. Here, oh, sorry, Aaron. Sorry.
Alright.
Let's try that one again. That was a little bit uncomfortable. It shouldn't have been. Sorry about that. There. Sorry. You cool?
better.
All right. I think I was a little too close to the orbit, to be honest. That was my bad, Aaron. How many fingers do I have? So the temporalis. And that temporalis muscle is much thicker than what you think, right? I mean, she took a 15mm needle like it was her job. And acupuncturists, they actually advocate taking 30mm needles and purposefully needling onto the lateral orbit of the eye. I do not advocate that. But Tai Yang, which sounds like an amazing dish. Tai Yang. Right? But, all right. I'm now going to come back to Yu Yao in the brow, and I'm going to go one shun proximal. This would be a point called gallbladder 14 for the frontalis. 14. Top of the bone, there's not a lot of tissue. Always squeeze and pinch into the tissue. In the Chinese would have put this up, these points, right? Up, down, I like it better down, doesn't really matter. A half chun lateral and a half chun superior of gallbladder 14. That would be gallbladder 15. for the frontalis. And if I go,
What was the numbers again? Half chun lateral.
it's a half chun lateral, half chun superior. And if I go a half chun medial and a half chun superior from gallbladder 14, we get to gallbladder 13. Pinch the tissue, needle into the pinch. If done correctly, then gallbladder 13, 14, 15 will make a V. Is to do gallbladder 13, 14, and 15 bilaterally. And then I would run electric on the points that are closest to the hairline. And I would use 2 channels like this, because there's going to be 4 needles, right? Gallbladder 13, gallbladder 15, gallbladder 13, gallbladder 15, like this. This is really therapeutic for someone with tension type headaches, and it is far enough away from the eyes where you can get away from it. Stomach 8, also for the temporalis, is a point which is just posterior of the lateral hairline. Here's the lateral hairline. And a point which is in line with the top of the ear. We're going to needle, in this case, A to P, perpendicular with the muscle fibers of the temporalis. That is the anterior superior aspect of the temporalis. So again, Tai Yang stomach 8 bilaterally. Gallbladder 13, 14, and 15 bilaterally. And Yu Yao in the brow bilaterally. Those are my favorite points for tension type headaches. If one side only, according to the definition, and these are the points that I would use. The only other points that I think are useful are related to the sinuses. I think you guys realize that if the sinuses are stuffed, then that can be a contributor to headaches, adds pressure, right? Even if the sinuses aren't stuffed, though, it can be a contributor to headaches. How? Because the sinuses are innervated by the trigeminal nerve. Okay? So I'm going to give you a couple points for sinuses. This is a great party trick because it will make the sinuses drain in real time. There will be a river of mucus, which will go this way, not this way, this way. And the patient will tell you, we put these needles in, they'll say, oh my God, like my right nostril is completely clear now, right? Taking the pressure off, certainly that could help with the headaches. You can do this on both sides as well. It's a hard sell though, for us to say that we're treating sinuses as physical therapists, especially in the state of Florida. What's called the labial nasal groove. The labial nasal groove, which are the patient's snarl lines. These guys, a lot of you ladies like to get like fillers and stuff in there, right? Can you snarl for us a little bit? Snarl these lines, right here. Okay. If you go to the highest point in the labial nasal groove, it's a point called bitongue, B-I-T-O-N-G. And you're going to take the needle, you're going to go straight down there. And you're just going to go down to the sinuses. Now, the way to think about this, because you are hitting the bone a little bit, you are not doing periosteal pecking. I am not trying to cause damage, trauma, bleeding, any of that. Think about it this way. You live in a neighborhood where the mucus also lives. Just tap, 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 tap. It's enough. And the levator labii superioris. But seriously, who's got a levator labii superioris problem? You know what I'm saying? Kentucky, you get beat up for stuff like that. What's the ICD-9 code for the nasalis? Right. I'm going to go to the inferior aspect of the nostril. Almost like you're getting ready to pick the patient's nose. And then you're going to come directly lateral into the labial nasal groove, and then put the needle. That would be the same two muscles. Down to the sinuses, and then just tap, 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 tap. It's enough. To explain stomach 3 is this. If you draw a line directly over from the inferior aspect of the septum, and then you draw another line directly down from the pupil, where those two lines intersect is stomach 3. That'll put you in the inferior aspect of the labial nasal groove. Do be careful on this one, needs to be right. If it's wrong, then you become a dentist. Patients don't like that. So if done correctly, it will look like whiskers. And honestly, if the sinuses were involved, I would definitely do both sides. Let's keep in mind that many of the points that I'm showing Bell's palsy and systematic reviews, it is legit. Don't think you can't treat that. Some additional points that you could consider for Bell's palsy that I like. That last one was, oh yeah, stomach 3, the last one. And that would be for the zygomaticus. I should have said that, sorry, zygomaticus. Nobody has a zygomaticus problem. So for Bell's palsy, I would consider stomach 2, which is the infraorbital foramen for the drooping of the eye. I would consider the buccinator for the drooping of the mouth. Mental foramen. Top of the orbicularis oris. I'll show you on the blog site. I have a nice article. It reviews all the points for Bell's palsy. The thing to remember about Bell's palsy is be careful on the stimulation. Too much stimulation too fast on a patient with an acute Bell's palsy is not right. Because if you take a nerve which is trying to regenerate and you stimulate it too much, you can make it worse, right? So an acupuncturist for an acute Bell's palsy, they would actually start by needling the opposite side of the patient's face, which is kind of cool. Then they'll come back to the side in question and they just put the needles in. Then they put the needles in, light manual electric stimulation only. Then moderate manual stimulation. Then they add electricity, light, and they build it up. Can you appreciate that? Just be careful, not too much too fast. If you go one index finger forward of the tragus is the little flappy flap in front of the ear hole, right? Some of you ladies like to pierce this one. One index finger forward of the tragus brings me to here. That'll bring you to the zygomatic arch. Is the bad side up, by the way? Mm-hmm. Okay. If you fall off the zygomatic arch inferiorly, there, and you push straight down, is that not the bullseye of your symptoms? Mm-hmm. She knows it's right. Mm. In 11 out of 10 patients, which is impossible, that's where it hurts. Now, that is the masseter proximally, right? Because the masseter does insert there. But if you go deep through the masseter, it's the inferior head of the lateral pterygoid. This point is stomach 7. It is the money shot for TMJ. Do you want me to fold this so you're not hanging?
Yeah, that would be great.
That'll bring you to the zygomatic arch. Fall off the zygomatic arch inferiorly. And you want to be on the zygomatic arch, like not hitting it, but right under it. This muscle is small. It is easy to miss. And we're going to go straight down right here. No angle. You okay? Mm-hmm. And that's usually the response that you get. I'll change it just slightly. That's better. Soon as you hit the inferior head of the lateral pterygoid, she'll let you know. She knows. Now watch this. if I just stimulate it just a little bit, I barely touched it. Is that your symptoms? Yeah. Inferior head of lateral pterygoid. Now, if I do this, I'm just talking, okay?
Okay.
And these patients are like headache patients. They're very sensitive. You got to take your time. I was actually expecting this to be much more, a little bit deeper, to be honest. You're pretty shallow. Not as a person, I just mean. Sorry, I know I'm torturing you. I'm just trying to get it in the best spot. That's better. That's different, isn't it? Are you clapping?
Just tapping out.
It's an odd time for a round of
Tapping
applause.
out.
Off the tip of the needle, just a little bit underneath the zygomatic arch, just a little bit. That would be the superior head of the lateral pterygoid. That would be my second go-to. I would not do both of them at the same time. You got to choose. I would always go inferior head until you start to plateau, then go superior head if you need it. And oh, by the way, that's been shown in the literature to be solid. They have looked at what I just showed you on cadaver studies, and they've done it with diagnostic ultrasound, and they have confirmed that you can put the needle into the inferior and superior head of the lateral pterygoid with the instructions I just gave you. 5 degrees inferiorly with a slightly longer needle, maybe not on her, but you would hit the medial pterygoid. Now, I don't think that the medial pterygoid makes a damn bit of difference when it comes to TMJ, because the medial pterygoid does exactly the same thing as the masseter and the temporalis. However, the medial pterygoid is the money shot for somatosensory cervicogenic tinnitus, the ringing of the ears. If it is the fault of the muscles of mastication, it's the medial pterygoid. Why do I say that? Because the medial pterygoid is the only muscle of mastication that has cross fibers with the tensor tympani, and the tensor tympani attaches to the eardrum. So if you were to put a needle into the medial pterygoid and the patient says, man, that makes my ringing worse, now you know it's game on. Because that means to me, the medial pterygoid is driving that. And then you can use the same needle as a treatment in order to tone that down over time. I don't care what you do, stomach 7. Now, finger in front of your own tragus. And now I want you to open your mouth as wide as you can. Can you feel that hole that opens up in front of the tragus? We're gonna put 2 needles in that hole, not your ear hole, that hole. And we're gonna needle in and a little bit up. That will get the tips of the needles into the posterior capsule itself. All right, open for me. That's good. You can hold it open there for me. Excellent. Nice. Open. Good. Enough. You can relax. 2 in the hole. In and a little bit up. Open. It's enough. It's fine.
Gallbladder 2.
2. Manually, light. Watch. Just a little bit. A little love. Look at her. Is that your symptoms? Yeah.
You say the top one is
GB2. Gallbladder 2.
Sorry.
That's okay. It doesn't matter what you do. You have to put these 3 needles in. And I would stim these needles every 4 or 5 minutes. Keep it light just to reproduce the patient's symptoms, right? Elicit the Dirty response. Manually stimulating these needles continuously every 4 or 5 minutes over a 20 or 25 minute period of time is important. Dunning and I disagree on this to either of the 2 that are in the capsule. And the reason is I like to treat this as an osteoarthritic joint. If I can prove the vasodilation to that joint, right, then we get all the same benefits as we did with the shoulder, the knee, the hip, increasing the blood flow, delivering more opioids, delivering more factors of lubricate, all of that stuff, right? But I would only turn the electric up to the place where the patient can feel it. I would not take it to strong and uncomfortable, but not nasty painful. You're on the face with electric. The distal masseter on the mandible. So if you look at me, I'm a clincher. And if I clench my mouth, can you see this muscle right here? Right? That's my masseter. We're gonna try to hit the masseter as it's coming into the mandible. Right? We're gonna hit the front of the masseter. That's stomach 5. And then we're gonna try to hit the posterior aspect of the masseter, stomach 6. Stomach 5 is about 1 shun forward of the angle of the mandible. About 1 shun forward of the angle of the mandible, and you're needling onto the mandible itself. Stomach 6 is just forward of the angle of the mandible. No, I've changed my mind. I'm going to move this one just a little bit, just to make it look a little nicer. Not you, the needling, you know. This is the quietest that you've been all weekend. Should have your husband call me. Of mastication, as you know, based on its attachment onto the coronoid process. So I can throw Tai Yang back in. I'm actually going to use a purple this time. I'm just going to go in 15 millimeters only, just to give her a little bit stronger treatment effect. A little extra love. Not going to the bone, it's plenty. But that's different, isn't it? The feeling there was a little different, right? Would be my go-to for TMJ. It's legit. This is 5-6 treatments. Now, you ain't gonna get rid of 30, 40 years of wear and tear, you know what I'm saying? You ain't reversing 30 years of eating. Truly have the problem. It takes a lot more priming. You can always add more pronation, more wrist flexion, right? And then your thumb comes right behind the head of the radius. And you're priming it 7 or 8 times, just kind of coming back and forth. I'm not gonna do it yet. You're kind of coming back and forth, right? And at the moment of truth, you gotta keep this on, and then you thrust through this way. And what gets it to crack is it's not the movement this way, it's the ricochet, it's the boom. That's what cracks it. So, because it's kind of sucky. The real large intestinal leaven is halfway between the biceps tendons at the elbow and the lateral epicondyle. And if I come halfway in between those two structures, it brings me to here. Right? And if I asked her to extend her wrist, right, can you see how that misses the common extensor tendon? So a better way to think about it is, let's go 1 shun distal and 1 shun medial of the head of the radius. Let's remember that if I put her in anatomical position, that the head of the radius is on this side, right? All I'm doing is just pronating her over, so the radial side of the hand is over here, but that doesn't change what's going on with the head of the radius at the elbow, right? So 1 shun distal and 1 shun medial of the head of the radius brings me to here. And now if I have her extend her wrist, can you see how that puts me at the peak of the bulge? That's the common extensor tendon. I would also confirm that that's nice by having her go middle finger up and down, up and down, up and down. You're pretty good at that, huh? Good. And then she can relax. So we're gonna go right here. This is gonna be a modified large intestine 11. You could do a little fanning here,
Okay.
a little coning. Okay.
Mm-hmm.
Little middle finger, middle finger, middle finger, middle finger.
Kind of dead.
Good. And come back onto the lateral epicondyle itself. And here we want to find the place of greatest discomfort. Typically it's the distal part of the lateral epicondyle because that's where the common extensor tendon actually inserts, right? So I would feel with the patient and I would say, is this your symptoms here? Is that the worst of it?
Mm-hmm.
Yeah?
Yes.
Or is it more this?
More the first.
More the first, a little more,
Mhm.
this. Okay. Wherever she says the worst is, that's where I would put the needle. And this is the place where you want to get the needle down to the attachment. This is a tenoosseous insertion, and we're going to do some periosteal pecking here. So right down to the bone. And this.
Ooh, okay. Pineapple.
Now she should hate me for a full 10 to 15 seconds.
Yep, that does not feel great.
Easy. Hit the right spot.
Yes.
Steady.
Ow.
Kitty cats and puppy dogs. Rainbows and butterflies.
All right, we can stop.
And I like to connect these two needles with the base of the third. Because I want to work down the forearm. But I know that I can't needle all of the muscles that are associated with the common extensor tendon. I've got to choose. So what is the red-headed stepchild of lateral epicondylitis? It's the ECRB. Right? We know that the ECRB, it inserts onto the lateral epicondyle, and distally it inserts onto the base of the third. That's why the best special testing for lateral epicondylitis is resisted middle finger extension. Okay? So, if there's one muscle that I want to needle as I go down that forearm, it is the ECRB. Check your line, little middle finger, up and down, up and down. A little more, up and down. Just want to make sure my line is good. Okay, got it. Thank you. So from large intestine 11, I'm going to go 2 chun or 3 fingers distal. I'm going to stay on my line and put the needle into the ECRB for large intestine 10. If I go 1 chun distal of large intestine 10, I get to large intestine 9, and then same rules. Trying to stay on the line into the ECRB.
Still 2 chun distal or
1.
I'm sorry.
So 2 chun, 1 chun. And now if I go another 1 chun distal of large intestine 9, I get to large intestine 8. And then same rules. So you could say that the most famous distal point of all distal points, the most well-studied point in all of acupuncture, is large intestine 4. And large intestine 4 is considered the master point for any upper extremity related pain condition. I would say that you're justified putting in large intestine 4 for general central nervous system pain reduction. Any problem, waist up. You could even do it both sides. I wouldn't talk about it. I might not document it, but large intestine 4. That's not me.
That's me.
Strike one.
When he's putting that needle.
I know.
It has the second strongest ability to activate the sympathetic nervous system of any acupoint. The way that you find it is we're going to take the thumb and we're going to squeeze it together with the index finger. You see that beautiful bulge of muscle in between. That is the first dorsal interosseous muscle. We're going to go at the peak of the bulge, and we're going to go directly down into the first dorsal interosseous. Now, not...
Oh, that's me that time. Didn't know that was there.
This isn't so bad. But a little bit, no big deal. But watch her. We can't really watch her face with the mask, but watch what happens. I'm going to wind this up.
Mm-hmm. All right.
Right? Very quickly, we get a serious sympathetic response. Her hand might get a little bit sweaty, a little swampy, you know what I'm saying? We get a little puddle. Big time point. Large. That was over. This time I'm going to go one shun proximal of the lateral epicondyle, and I'm going to get to something called the Supracondylar Ridge. It turns out that there are two muscles that are part of the common extensor tendon that do not insert onto the lateral epicondyle. Instead, they insert onto the Supracondylar Ridge. Do you remember what those are? It's the extensor carpi radialis longus and the brachioradialis. If you feel like those muscles are involved, then I would definitely put in large intestine 12 onto the supracondylar ridge. And you can do a little periosteal pecking here too if you wanted to. And then we could have put a point in that you guys already know, which is large intestine 13. This point I showed you for the shoulder. It was 3 chun or 4 fingers proximal of the lateral epicondyle that brought us to the humerus. And if we fall off the humerus anteriorly into the depression between the humerus and the bicep, we could put a needle into the brachialis. It's a pineapple.
Pineapple. Pink love.
What was that?
Pink. Ow, okay.
Try to mix it up. All right, here's the way I think about the electric. I would run one current from the Ashi point where you did the periosteal pecking at the lateral epicondyle, and I would run it to maybe large intestine 8 or maybe large intestine 9 like this. I would take a second current, where I would go from the common extensor tendon, modified large intestine 11, and I would overlap it and come down to maybe large intestine 8. Can you see how I'm doing this?
Mm-hmm.
Totally cool. I need one more, if you don't mind. I got it. Thank you. And then if the problem was maybe a little higher, we could run large intestine 12 to 13. Now, if our protocol is good, chillin' here, chillin'. If our protocol is good, then I should be able to turn the electric on and look. See? F you. You know I'm getting that ACRB. Sharps is over there, maybe I'll take that up.
Are those two just Ashley points?
This one is.
How about the one above?
And they will tell you that they have distal biceps tendonitis. And you'll say, all right, maybe. Like, well, how do you know you have distal biceps tendonitis? So, because it's been bothering me for a long time. It's killing my hammer curls. Mm-hmm. I said, well, all right, let's take a look at where it hurts. So you'll go to the biceps tendon at the elbow, right? and you'll go onto them with your dirty fingers, digits 2 and 3. You'll take your thumb and you'll put it on the head of the radius. And I'll just kind of flip over the biceps tendon just a little bit. And I'll say, is that where it hurts? And they'll say, kind of, like that's really close, not exactly. And you'll say, okay. Then you're gonna fall off the biceps tendon laterally, like this. And then you're gonna squeeze. And you're gonna squeeze right down onto the head of the radius. And they'll come right off the table. That's not biceps tendonitis. That's the supinator. The supinator attaches right on the head of the radius there, right? They forget that hammer curls are supination too, right? And the supinator hurts them with pull-ups and all kinds of other stuff, right? So you needled the supinator as part of the common extensor tendon. What you didn't needle was the attachment of the supinator, the attachment on the head of the radius. So many of those guys have this problem, probably your guys, with a point called lung 5. So watch again. You're gonna take your fingers and you're gonna put them on the biceps tendon at the elbow. You're gonna take your thumb and you're gonna put it on the head of the radius. You're gonna fall off the biceps tendons laterally. And then you're gonna squeeze. And what you're squeezing in between your fingers is the brachioradialis. You're gonna put the needle in between your fingers, dirty fingers, and you're gonna needle towards your thumb. And you're gonna hit the head of the radius. Don't miss the head of the radius, because then you're gonna put the needle in your thumb. Okay. As soon as you hit the head of that radius, the patient should tell you that that's their symptoms.
Not my symptoms, it just hurts.
Oh, I thought you were doing a lot of hammer curls. Now you could do tap, 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 this sort of a thing. Large intestine 11, and then I would have run electric right there, just those two for the supinator. Does that make sense? No. Modified large intestine 11 was the one that I showed you for the common extensor tendon, and that's the muscle belly of the supinator. Here we're needling the tenoosseous insertion. And so if we can run an electric current on both, we're good to go. Now, in all fairness, that UPS pilot, I got him 95% better. Easy. Find the medial epicondyle. And the first thing that I would do is I'm gonna do 2 needles, not 1, 2 needles. Periosteal pecking at the place of greatest discomfort. The medial epicondyle is a little more finicky, I think. And the reason why you gotta do 2 is you gotta put a needle at the distal part where it hurts the most, clearly it does there. And then you have to put another needle on the lateral aspect of it, not the medial part, because that's where the nerve is, right? It's the lateral part, this part. Right? Both places. So.
Should not have done this.
I thought we were gonna be friends.
Oh man, no, not anymore.
That's the right spot though, right?
Mm-hmm.
Okay. Down.
That's actually gone better.
There. That.
Oh yeah.
That's the right spot. Okay. Easy. Steady. 3 seconds. 2 seconds. 1 second. Solid. Okay?
Yeah. I see stars. No,
Yeah.
no, I'm alright.
Should we hug it out?
Not yet. Once this is out, yeah.
Too soon? All right, now you got to do the lateral part. And I assume there's some stuff going on here. She knows it's right. Yes. No?
Not there.
No?
Oh.
All right. Sorry. Almost done.
You're not sorry.
I'm sorry right now. Hitting it though?
Yeah. Oh, yeah.
Okay, enough. Okay. Sorry for hurting you. Sorry. That's where the common flexor tendon is going to, I have your arm, is going to insert. And then this one is the lateral part, right? Not the medial part, because that's where the ulnar nerve is. The lateral side.
Okay.
Right? And then I did some periosteopecking there too. For love. Heart 3 is 1 shun distal and 1 shun lateral of the medial epicondyle. So here's her medial epicondyle. Not putting my fingers over top, but 1 shun distal and 1 shun, in this case, lateral to here. And if I have her flex her wrist just a little bit, then you see how that puts me at the peak of the bulge of the common flexor tendon. Is that uncomfortable there?
It's not as bad.
Not so bad? Okay. That. You said it wasn't so bad.
I lied.
Of the medial side, of the flexor side rather, right? Which is the, no. Most textbooks would say it's the flexor carpi radialis, because there's not a longus and a brevis. It's just the flexor carpi radialis. The worst instructions of all instructions. In our textbooks, this is defined as 4 finger breaths, distal and lateral across the forearm from the medial epicondyle, which brings you to about here. That'll bring you in the vicinity of the flexor carpi radialis. I would have her flex and radially deviate back and forth, back and forth, back and forth, and you can get a sense of where that muscle is, and then you can put the needle there. Something like this. Do be careful, the median nerve is here. Okay. So I don't want to go nutty there. But then I would run 1 current at the medial epicondyle, and I would run 1 current from the common flexor tendon to the flexor carpi radialis. 4 needles total. Any perineural needling protocol, entire body, this is the one that has the most evidence. You'll find this in systematic reviews, and there's no protocol that pisses off the OTs more than this one. And I'm all about that.
Make good friends that way, right?
Yeah, no. So I want to show you that you've got a couple different creases on your wrist. You have a resting flexion wrist crease, and then you've got an active flexion wrist crease. The one that's resting is the one that's there at rest. It's the one that literally connects the arm to the hand. Show it off, show it off, show it off.
Wow.
Okay. And then you have an active one, which is only there when you actively flex the wrist. It's about 1 pinky proximal of the resting one. Show it off, show it off. Needling of the median nerve. So the game that we play here is, how close can we get to the nerve without physically touching the nerve? I would like it if we could be in the perineural tissue, like the tissue which is around the nerve. If I could get maybe just like a little bit of tingles or a little bit of something, you know what I mean? That's cool. What I don't want is a lightning bolt, right? A lightning bolt means I hit the nerve. If that happens, I would retract the needle and I would say to the patient, I'm sorry, I was just a little bit too accurate. Wasn't trying to be so good, right? I wanted to be in the vicinity, but I actually hit your nerve. Remind them that no acupuncture needle has ever been shown to cause nerve damage. Hypodermic needle, yes. Acupuncture needle, no. Theoretically, if you pinned it against a bone and you pistoned it, then yes, but I'm pretty sure you're gonna get beat up first, right? So we're not doing this with imaging, so it is possible. 1 in 20 times, 1 in 25 times, you may actually hit the nerve. Move it a millimeter, change the angle a little bit, reinsert it, don't catastrophize it, it's gonna be fine. In a worst case, the patient may have some lingering tingles or some lingering something, maybe 15 minutes. For the first time, I'm gonna advocate going slow. If you put these needles in slow, you can see it on diagnostic ultrasound, the nerve will actually move out of the way. It's not just gonna take the needle, all right? So go as slow as you want on this one. We're not trying for a localized twitch response or anything like that, but you'll prevent hitting the nerve. We wanna start at the active flexion wrist crease, the one that's more proximal. And we're gonna go in between the palmaris longus and the flexor carpi radialis. Palmaris longus, easy to find, opposition, little flexion. He's got a solid one, among the best I've seen. Show it off, show it off, show it off. Solid. Mm-hmm. All right, show me again. Good. If you don't have a palmaris longus, show me again. Good. The best you can do is find the flexor carpi radialis and fall off of it ulnarly. That'll put you as close to the carpal tunnel as possible without being in the carpal tunnel, okay?
Mm-hmm.
Sure?
Yeah, just don't like needles.
Pericardium 7 is the point. You can relax. Pericardium 7. Turned out that way. Pericardium 7.
Can you say that? Yeah, say the landmark.
Yeah. So I'm on the active flexion wrist crease, and I'm in between the palmaris longus and the flexor carpi radialis. Proximal of pericardium 7, you get to pericardium 6, and then same rules. We're gonna go in between the palmaris longus, show me again, and the flexor carpi radialis.
You said
2 Chen, 3 fingers. If you looked at a netter's, that'll put you right where the median nerve is supposed to be. You okay?
Mm-hmm.
Interesting fact, this is one of the 2 most famous points used in all of acupuncture for nausea. So morning sickness, nausea due to chemotherapy, any of that stuff. So it's a point called stomach 36. Stomach 36 is if you go 3 Chen or 4 fingers distal of the lateral eye of the knee. The lateral eye is where they would put the needle if you wanted to do a joint injection, right? 3 Chen, 4 fingers distal, that'll bring you to the tibia. If you go a half Chen off of the tibia and then needle through the tibialis anterior, lateral to medial, needling onto the tibia bone itself with a bony backdrop, this is stomach 36. This is the second point that's most famous for nausea. And acupuncturists would say that the purpose of this point is to block the rebellious chi back to the stomach. Stomach 36 and pericardium 6. Pericardium 6, I get to pericardium 5. In between the same 2 muscles. The the palmaris longus and the flexor carpi radialis. We skip pericardium 4 because it has nothing to do with the median nerve, but pericardium 3 does. Pericardium 3 is at the elbow. If you find the biceps tendons again at the elbow, and this time, instead of falling off of them laterally, we're gonna fall off of them medially. It should be there, because that's where the brachial artery is. I don't want to needle straight down into the brachial artery. Rather, I'm gonna needle medial to lateral, needling over top of the brachial artery, but underneath the bicep tendons. That'll put the tip of the needle where the median nerve is at the elbow. Pericardium 3.
Can you explain how you find that?
Yep. So into the biceps tendon at the elbow. I fell off of the bicep tendons medially. And then I needled medial to lateral, needling over top of the brachial artery, right? But needling underneath the biceps tendons. I'm now gonna go 2 chin or 3 fingers distal of pericardium 7 to get to pericardium 8. Now, there's no doubt about it, guys. You're on the palm of the hand here, right? There's a whole lot of sensation on the palm of the hand. A lot of guide tube, a lot of nice. Take your time here, right? And then when you're ready to roll, no monkey business. You're gonna get the needle in, and you're gonna needle back in the direction of the carpal tunnel. Get it there. Sorry. That's the one that's most noxious. The idea is to get the median nerve as it's branching to go towards the thenar eminence.
What's the distance on that?
It's 2 chin or 3 fingers. Just making it straight. Neural?
Yep.
You okay there?
Nope.
No? Still neural?
Yep.
Sorry. You okay?
Ah, no.
Okay.
Yeah.
Oh, way too accurate. All right, I'm gonna change this.
Nope. Still there.
What's your problem?
A lot of use of that middle finger.
Yeah. All right, I moved it.
Okay.
You okay?
Nope.
Tingles or
Yeah,
lightning?
now it's in
bolt?
more fingers. Both.
Okay.
Okay.
You okay?
Yeah.
Okay. That was rough. CrossFitters and Olympic lift guys, that because you guys are doing cleans and then the bar is ending up here, do you know what I'm saying? And I feel like you got a lot of entrapment and you get a lot of needles and 3 different muscles. Is there any questions on what I'm showing you?
So on those, it's not necessarily a measurement, just going into the muscle.
Yeah.
Right. Okay.
I mean, I think it's easier to see that way. Electric is important here, as with everything. And the way that I think about electric is this. I like to run 1 current at the carpal tunnel, pericardium 7, and I'll come to either pericardium 5 or 3 at the elbow. Then I like to run another current through the carpal tunnel. So I'll go pericardium 6 to pericardium 8 through the carpal tunnel. And then finally, I will go modified lung 10 to modified lung 10 if in fact they have thenar symptoms. Not buying it.
I'm just.
I feel like there's a lot of patients who still have problems, right? Median nerve, and it still feels like they have carpal tunnel. I don't really think it's like the same carpal tunnel anymore. In fact, I think a lot of those patients, it's more because of scar tissue, right? And if you can really get the scar under control, then that pain goes away. So I do want to just talk about scar tissue for just a second. Is there anybody that wants to take a quick pic of this, or what do you guys, is it okay if I take this out?
Come out.
Fake, brown, streaky scar. I usually like to talk about scar tissue within the context of carpal tunnel, just because I feel like it's a really big deal when it comes to carpal tunnel problems. Also a big deal for total hips, total knees, ACLs. I mean, any sort of surgery, you know that scar can be a really big deal. This is the one thing where I think you don't have to wait 8 to 12 weeks. You're not needling deep here. We're only needling through the scar tissue, right? I would say that if you're justifying doing cross-friction massage, you can justify needling for scars. Got to make sure it's closed, got to make sure it's healed, got to make sure that there's no signs of infection, etc., etc. I'm going to use the purple ones on him, but I don't want you to be confused. I would absolutely not use the purple ones in the clinic for scar tissue. I would use short, thick, brown needles. The shorter and the thicker, the better, right? But obviously he's sensitive. So the way I think about scars is two different ways. Number one, I like to keep it guessing. So you're gonna needle lots of different directions, and we're only gonna needle through the scar tissue. I'm not trying to go deep. Maybe we go lateral to medial, medial to lateral, straight in. Oops. I'll get it in just a second. All right. Lateral to medial again, or maybe medial to lateral. But the idea is we needle in lots of different directions, all the way up and down the scar. Keep it guessing, sort of a thing, right? And then once you do that, then what you can do is wind everything up hard. Wind it all the way up, get it all the way into that pineapple sort of a thing. Now, scar tissue doesn't normally have nociceptors because it's scar tissue. Underneath there's nociceptors, but it really shouldn't be that bad if you wind that scar up really hard. Wind it up, right? You really want to wind it up around the needle. And then when you do, you're going to wind it up, and then you're going to do bilateral pulls like this. And hold it. And then this. Hold it. So you're going to pull, 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 all kinds of different directions, from different directions, right? The idea is you want to break down that scar tissue, right? You really want to restructure it. You want to create better range of motion for whatever reason, like it's adhesing down, and that's what's causing problems. Remember, in 1979, Lewitt needled successfully 33 of 35 scars. Same needles. He took the pain at the site of the scar away, and he took pain that was unrelated to the scar. He took that away too, right? So needling for scar tissue is a really big deal.
Is that just like for pain, or is it just also for like keloid scarring? And
so keloids is a separate thing. Yeah, right. Last thing. I was kind.
Gentler second time around.
Yeah.
So you're running all 6 channels with the scar?
No, one channel. If it was a big ass scar, maybe 2, you know, so that sort of a thing. You could also use a technique which is called threading. So you could come to the end of the scar and you could needle like parallel with the skin, and you would needle up the scar, like really, really staying superficial like this. And then you could take the needle and wind, wind, wind. Look what I'm doing here. Well, I've got his arm here, but wind around the like this, right? And then if you came from both sides, I would pull like this.
Right.
Right? And you could play it that way too. So you could thread it, and then needle in different directions in between. That's nice too, right? You can't really go wrong with scar tissue. It's better than any cross friction massage that you will do. But don't forget about scar tissue. And that's a really nice way to justify using some of these distal points. These distal points, acupuncturists get really possessive with these points. Even my friends that are acupuncturists and they know that I teach, and you know, off the record, they're okay with us doing dry needling and teaching it. They always say, well, do you teach the distal points? And then I say, of course I teach the distal points because we treat radiculopathy. And then there's awkward silence. Because what are they going to say to that, right? Nothing. I just want you to understand that there's a whole lot of reasons for using these points. I think acupuncturists overuse these points. Really, really powerful points. Again, this is the master point for any upper extremity related pain condition, great for any central nervous system pain reduction. No point has been studied more than this one. I'm going to show it to you for a C5, C6 radiculopathy. Okay. If you take the thumb and the index finger and you squeeze it together, you get a beautiful bulge of muscle. And you go to the peak of the bulge, And then you needle into the first dorsal interosseous. That's large intestine 4. Snuff box. So you guys remember anatomical snuff box from school, right? It's where you put the drugs right before you sniff them.
Yep.
Right? I don't want to go into the center of the anatomical snuff box. Extend that back for me just a little bit. I want to, because the vessel's there, I'm going to go between the center and the dorsal tendon. This dorsal tendon is the extensor pollicis longus tendon. And we're going to sneak it right underneath that tendon. Like that. Large intestine 5. I'll show you for a C5, C6 ridic. Would be lung 7. Lung 7 is 1.5 chun proximal of the anatomical snuff box. And if you feel there, it feels like there's a depression on the radius, but it's really not a depression on the radius. What you're feeling there are the tendon sheaths of the de Quervain's tendons. I want to go into those tendon sheaths in a direction which is proximal to distal. Like this.
About 45, 30 degrees.
It doesn't matter. Something like that. So these 3 points would be really nice. Let's say you had a patient, they came in, they had neck pain, radicular symptoms, consistent with a C5, C6 pattern, right? You did the McKenzie, you centralized the symptoms, the patient's neck is a hell of a lot better. They come back and they say to you, man, I'm 90% better. In fact, the only symptoms that I have is I still have numbness here, or I still have tingling here, right? We've all seen that patient. What the poop do you do with that, right? Do you tool it? Do you stretch it? Do you cup it? Do you exercise? I don't know what to do, you know what I mean? Run lots of electric there. Those symptoms will come out in maybe 1 or 2 treatments. Or you could use this in addition to your McKenzie, not at the same time, but maybe within the same treatment. And you could maybe put in the Htj and the bladder channel points to needle the cervical nerve roots, perineural needling of the nerve roots, and then you could put these points in for the distal symptoms of the nerve, and then you can fill in. Lung 9 is back in the anatomical snuff box, but this time we're going to go in between the center of the anatomical snuff box and the ventral tendons, because the ventral tendons are the de Quervain's tendons. That's lung 9. For de Quervain's, I would use purple needles, and I would do lung 7 and lung 9, lots of winding, and I would run electric right here. I can't tell you how good that is for de Quervain's. Nothing will piss off the OTs more. Well, I'll give you 3 points for 4 is in the extension wrist crease. If you extend the wrist just a little bit, there's a beautiful depression that pops out that, well, it doesn't pop out, it's a depression, right? But you can feel that depression. That's where triple energizer 4 lives. Wow, lots of vascularization on you, huh? So I'm gonna avoid the vessels. Good God, man. Triple Energizer 4. 5. Triple Energizer 5 is the most powerful point of these 3. And it's a point which is 2 chun, or 3 fingers, proximal of the extension wrist crease, in the depression between the radius and the ulna. So this is a really nice one, I think, for older people. Because a lot of older people, they have a lot of pain here in between the radius and the ulna. It's because they're constantly like pushing on chairs, or they're pushing on their walkers, or on their cane, right? There's constantly pressure going there. And I think they have inflammation of the aponeurosis in between those two bones. If that were the case, I would use purple needles here, in between the radius and the ulna, and I would put a couple of them in there. And I would wind the needle into that aponeurosis. I would run electric there, and you will be able to take the pain away. Which has to be small intestine 3. If you take your hand and you put it into a loose fist, and you go to the base of the 5th finger, can you see how it makes a little baby butt? See a little baby butt there? We're gonna put this needle, small intestine 3, right in the baby butt. And we're going right there. Small intestine 3. And the hamate. Do you remember the carpal bones? Sally left the party to take Kathy home, or whatever dirty way you learned it, remember? We're gonna go to the pisiform, and we're gonna fall off of the pisiform distally. Right? There's a depression between the pisiform and the hamate. And that's where small intestine 4 lives. And then finally, the most important point of these 3, in my opinion, is small intestine 5. Small intestine 5 is in the depression between the styloid process of the ulna and the triquetrium. Oh, no, he didn't. Yes, the triquetrium. If patients, I would get 2 purple needles, and I would put 2 needles into that depression between the styloid process and the triquetrium. I would do a little pecking into the TFCC, cause a little bleeding, a little trauma, wind those needles up, and then run electric there, right into that depression. I can't tell you. Patients will come for that. That will clear up TFCC. 1, 2 treatments. It's that good. T1 radiculopathy. But if you have somebody just with general pain and you'd like to put in some distal points, the most powerful distal points would be large intestine 4, triple energizer 5, and small intestine 3. You're kind of always justified putting those points in. You could even do it bilaterally. I might not document it, I might not talk about it, but you could. If you ever get called on that, you're not, but maybe everybody else, right? And they're gonna say, well, how is that not acupuncture? Take a look at my article. I have a section in the article. Of course, I'm not supposed to talk about this, but if you look in systematic reviews, one of the most evidence-based things that you guys can do with needles is treating neuropathy. And I know you guys got those patients, right? So, for patients that have symptoms in the hand or in the feet or any of that stuff, you can look in the literature and you'll see all kinds of special points for neuropathy, and they're good. But if I could just give you some starter points, the most evidence-based, the most famous points for neuropathy are called the Bafang and the Baxi points. The Bafang and the Baxi points. You will find throughout the literature a significant decrease in sensitivity, an improvement in 2-point discrimination, and a significant improvement in function due to an ability to feel again with the hands and the feet. It's powerful. Same thing with the feet. You go into the web spaces in between all the toes. Same premise. It would just be a shame if you didn't know that. I did not learn that from Dunning. That's stuff I learned in Europe. But they do that all day, every day in Europe. And then
feet, do you curl your toes? And
no,
like,
don't be weird about it. Yeah,
okay,
no.
no, I'm trying to visualize where he's wearing flip-flops.
Oh yeah, I'm not just talking. So you just go in between the toes. Do you know what I'm saying? Just right in between the toes, each one, you know.
Okay.
No crunching or anything, right? The biggest thing that you could do wrong here is if it's like such neuropathy that they have all kinds of wounds and we're doing wound care and all, like you can't add more compromise into already compromised tissue, of course, right? But you can help a lot of people. And then finally, I always like to give a shout out to the CMC joint. This one, right? You guys know that this is the first joint that degenerates on the hand. Nobody knows this better than the ladies. I feel like this is a big time lady problem. So really well for the CMC joint. It's not rocket science. Here's what I think, here's what I do. Just hold that there. I take 2 needles and I go proximal to distal, and I wanna get the tips of the needles as close to the joint line as possible, maybe even a touch into it at the CMC joint. Then I take 2 more needles and I go distal to proximal like this, and I cross it. You're treating this as a super small, super cute osteoarthritic joint, right? It's the same premise as the hip or the knee. The more electric that you can get crossing that joint, the more that you can increase the blood flow, the more that you can deliver factors of lubrication and opioids and drive down the factors of inflammation, and the more that we can start to reverse some of the signs and symptoms of the degeneration. Remember, anytime that you have osteoarthritis of a joint, a degenerative condition, you're thinking longer with the electric. Not 20 minutes, 30 minutes I would do with this. Needles out, I would do joint mobs, all directions, distractions, and then a lot of moist heat. If you still have paraffin in your clinic, this would be a good time for that. Paraffin is where we take like a bath of wax. It's so embarrassing. And then the patient sticks their hand in it. And then we charge them for paraffin.